All right, good afternoon, everyone. Welcome to why vaccine preventable diseases are still causing global health emergencies. I am your room host with the virtual in/in-person hybrid model we've got going on here. I'm Ian Kilburn from Vermont Emergency Management. Just a couple of things before we get underway. For those of you in the room, just note the emergency exits if the event in which we have some sort of catastrophic emergency. Please just freak out and run like crazy and bump into each other. No, I'm just kidding. The one door all the way in the back just leads you deeper into the resort, so try and use these ones up on the front. For those of you at home, well, you're kind of on your own. And then feedback, Hillary Scott will be emailing a little later on during this conference for your feedback, so please, your feedback is important to us, so we would like your honest opinions. So without further ado, Abigail Spiegelman, take it away.
All right, thank you, Ian. Can you give me a thumbs up or say you can hear me? I just want to make sure I unmuted.
We can hear you.
Perfect, thank you. And my plan is to leave my camera off during the presentation, and then I'll turn it on for questions. And since I can't see y'all, if there is some sort of catastrophic event and you're running for the hills, please someone get me, because I won't know. So thank you all so much for being here today. I will be, like Ian said, today I'll be presenting on why vaccine preventable diseases are still causing global health emergencies. And for some background, vaccine preventable diseases are those diseases that could be prevented by an already existing vaccine. So for example, that includes measles, polio, diphtheria, yellow fever, and meningitis, just to name a few. COVID-19 is now also a vaccine preventable disease. And the CDC recommends vaccines for 18 different diseases, the vaccines for which have saved millions of lives since they've been created. So the first thing I want to cover is, why are we even talking about this? So this graph shows global vaccine coverage from 2000 to 2018. And as you can see, global vaccine coverage for the selected diseases have been increasing. And so if that's true, why are we still having these, outbreaks of these diseases? So this map shows the number of vaccine preventable disease outbreaks in 2008. And remember, vaccine preventable diseases are those diseases that could be prevented by an already existing vaccine. So as you can see, we have a couple in the United States for whooping cough. We have measles, a few throughout Africa, Europe, and Asia. We have some polio in Southeast Asia, but it seems like a manageable amount. So this next map is 2018. So just 10 years later, it shows the outbreaks of vaccine preventable diseases across the world. And as you can see, there's been a marked increase. Measles throughout Europe. We have whooping cough throughout the US and measles. We have a lot of blue is cholera. We have a lot of that in Africa. So there's just been a marked increase in vaccine preventable diseases just over that 10-year period. And this was before we had even heard of COVID-19. So this is in 2018. In 2019, almost 1.7 million people died from a vaccine preventable disease around the world. And just to put that in perspective, that's almost 3 times the population of Vermont. So that's a huge amount of people who died from diseases that could have been prevented by existing vaccines. A lot of those are tuberculosis, some are meningitis, but regardless, these vaccines exist. And to narrow our focus a little bit, in the United States alone, there were over 2,000 deaths of vaccine preventable diseases in 2019. And that was before we'd even heard of COVID-19. So that number has increased exponentially since the COVID-19 pandemic hit in 2020. But earlier I showed you a graph that vaccine coverage was increasing. So these two facts seem to kind of contradict. And so I want to talk about why this is happening. In order to understand that, and before we go into depth on everything, there are some terms I want to make sure that we all understand. The first one I want to highlight is herd immunity. Herd immunity is when enough people in the population are fully immune to a disease. so that even those who are not protected, like who are not fully immune, are still protected against infection. And this can happen through vaccination, or if a person contracts an illness, fights it off, and then becomes immune. Obviously, getting vaccinated is safer for the individual, and it can be cheaper economically down the road. So that instead of treating people, you're getting them vaccinated. But regardless, enough people have immunity that even those who don't are still protected. The second term I want to go over, which I already have, is vaccine preventable diseases. As a reminder, those are the diseases that could be prevented by existing vaccines. But what I want to highlight is that I'm not saying available vaccines, I'm saying existing. Just because a vaccine exists does not mean that it is equally available to everyone. And I'll discuss that more in depth later. And the last term I want to cover is impacting factor. And those are those things that influence something. So for example, an impacting factor for flooding might be current infrastructure or climate change, but they're those things that impact a disaster. Now that we know those terms, I want to look at this graph again, and specifically, I want to highlight this red line that's right here. So this red line covers the second dose of the measles vaccine. In order to achieve herd immunity for measles, 95% of the population needs to be fully immune. And remember, that can come from vaccination or getting measles, but obviously we would want the population to be vaccinated against measles and reach herd immunity that way. Regardless, we need 95% of the population to be fully immune in order to achieve herd immunity. As you can see from this graph, only 69% of the population has received the second dose of the measles vaccine. And that's clearly not enough to achieve herd immunity for this specific disease. We're at 69%, we need to be at least 95%. And if we look at this graph for the last couple of years, you can see that a lot of the vaccination rates have started plateauing. They've stopped their drastic increase and started plateauing. So what all this means is that even though global vaccine coverage rates have been increasing, they're not increasing to the point that we've reached herd immunity for these different diseases. So people are still susceptible and we still get outbreaks, which is what we're seeing. What are the possible reasons behind an increase in vaccine preventable disease outbreaks? And I want to take this moment to say that this is a highly complex issue. There are thousands of factors that go into this. I will be giving a very high-level overview of one specific factor, which is low vaccination coverage. But other possible factors are crowding. So as climate change increases, you've got urban and climate migrants. People are crowding into the same place. Communicable diseases can spread more easily. Poor sanitation, same thing. We learned from COVID, we gotta wash our hands. If we don't, things can spread. Malnutrition. If your body is weak because you're not getting nutrition, you're more susceptible. Your immune system isn't as strong. And human mobility. As the US, not just the US, as the world goes through globalization, travel becomes more effective, more affordable, more ubiquitous. People are transferring diseases from all over the world to places that haven't ever seen it before. Like COVID, it spread through airplanes. Like Ebola earlier, normally we are just used to hearing about Ebola in the African continent, but we saw it in the US because of globalization. So this is a highly complex issue, like I said, but for this specific presentation, I'll be focusing on vaccine hesitancy, which fits into that low vaccination coverage section. So within low vaccination coverage, these are just a few of the many reasons that could impact low vaccination coverage. Social media and the spread of misinformation. Everyone has a phone, everyone has Facebook or Instagram, and information spreads so much more quickly than what it has in the past that it's hard to keep up with. Education, I'll talk about in this presentation. Your education level matters in how you understand this complex information. Religion and ideology. I think we've all seen this with COVID-19. Your religion and your where you fall on the political scale impacts what you believe and how you believe about vaccines, if they're safe, if they're effective. Distrust of the West. American international relations, distrust of pharmaceutical companies. These all kind of tie in together in that people don't necessarily trust vaccines because they don't trust the United States, or they don't trust the West, or they don't trust the companies who make them. So trust is a huge issue when we're talking about vaccination coverage. Socioeconomic status and access to healthcare, those are tied together, because if you have a lower socioeconomic status, if you're experiencing poverty, you're less likely to get a vaccine. These things all make sense, but we don't always drill down to the reasons behind them. And one thing that's often overlooked is the interlinkage between these impacting factors. You know, if some misinformation is spread on social media, someone's more likely to believe it if they have a lower education level, and they're more likely to have a lower education level if they grew up in poverty. All of these things are linked, and that's a lot of times why strategies on vaccine hesitancy, I found they don't work, because we're only targeting one impacting factor at a time instead of looking at the overall linkage between them. So I want to highlight a couple of these impacting factors. Again, this is not all of them. There's so much more, but I'm going to highlight a few of what I found are the most ubiquitous. So the first one I want to highlight is social media and the spread of mis and disinformation. And the first thing I want to talk about is the difference between misinformation and disinformation. So misinformation is incorrect information that is spread on accident. You know, you truly believe something, and then you share it even though it's wrong. Disinformation is information that's incorrect, but it's shared on purpose. And a lot of times that's shared by bots or activists who are trying to, you know, rile up the different political sides. Two very distinct issues, but they have the same effect in that they're spreading incorrect information on vaccines. So, and one thing I want to highlight is The Guardian, which is a newspaper, found that Facebook search results from groups and pages with information about vaccines were dominated by anti-vaccination propaganda. And then they also saw that YouTube's recommendation algorithm steers viewers towards anti-vaccine misinformation and away from fact-based medical information. So not only is this a human issue, sharing incorrect information, but it's also a technological issue with these algorithms. So these specific two examples on the screen, on the left, you see a Facebook ad that claims vaccines kill babies and that mandatory vaccines should be stopped. This one ad had thousands of interactions. And remember, this is one ad of thousands. So you can see the impact that these social media ads can have. And on the right, this is an Instagram post that claims that the COVID-19 vaccine will permanently change your DNA. Neither of these things are true, but they grab your attention and play on your emotions. So the one on the left plays on your desire to protect your children. And then the one on the right, the one from Instagram, plays on your fear. It's easier and faster to engage a person's emotions than try to win them over with logic. And that is what those who engage in the anti-vaccination movement and vaccine misinformation, they do so well, is they know how to play on people's emotions. And so that's something we'll talk about later on a possible solution, is how to play that too, because a lot of times as emergency managers, as public health officials, we want to stick to the science. We want to stick to the facts, and that's good. But if we just stick to facts and logic, we're going to keep getting beat out by those who go the emotional route, because it just connects with people more. The second impacting factor I wanted to highlight was education. So a 2022 study in the American Journal of Infection Control showed that COVID-19 vaccine hesitancy was correlated with a lack of high school education. 50% of the most common reasons for vaccine hesitancy were related to a lack of knowledge about potential side effects, benefits, effectiveness, and the risk of being unvaccinated. So people just didn't understand how the vaccine worked, what its effects were. And then the authors of that article concluded that a lack of education, including knowledge gaps, would be a barrier to COVID-19 vaccine uptake. So I pulled that study because it's so recent, it's about COVID-19, but this is not just a COVID issue. This is an issue with all vaccines: measles, diphtheria, yellow fever, those ones I mentioned earlier. Polio, we're seeing that in the news now after decades of not having to worry about it. And so, though this study focused on a lack of high school education, other journal articles have shown that there's a correlation between any level of education and vaccine understanding. So the more education you receive, the more likely you are to understand that scientific information that's so important. And it's easier for people with less education to believe the misinformation that surrounds vaccines. So this particular graph is the breakdown of education in Vermont as of 2019. Obviously, COVID, stay-at-home orders will have impacted this education breakdown, but this is what it was as of 2019. So you have a significant percentage of the population who, though they have a high school graduate or some sort of equivalency, maybe doesn't have the education necessary to understand these complex scientific journal articles or information that are released. The next impacting factor I wanted to highlight is religion and ideology. And ideology can cover politics. So this does cover those political beliefs. And so for this particular one, I just wanted to give some examples of how religion and ideology play into vaccine hesitancy. So in 2003, there was a polio outbreak in Nigeria, and this outbreak was directly attributed to Islamic groups convincing their followers that if the United States would be willing to harm Muslims in the Middle East, because remember, this is right after 9/11, then the US would be willing to harm Muslims in Africa. And using this religious ideology as a foundation, they were able to convince their followers that the US and Western world had made vaccines that were unsafe, that their sole purpose was to harm Muslims. And so there was a polio outbreak in correlation with this, because you had all of these Muslims in Africa who were terrified to get the polio vaccine because they trusted their religious leaders. And they trusted that as Muslims, they weren't safe to take these US-made vaccines. In 2020, Christian leaders in South America told their congregation that chlorine dioxide was only dangerous to pharmaceutical companies and corrupt governments. If you were a true believer, you would be safe. And so, yet again, religion is used to convince followers that you don't need to take the vaccine, you can do this alternate treatment, however it works, you're safe, you don't need the vaccine. And then in the United States, researchers found that parents' belief in liberty and purity were the most associated beliefs with vaccine hesitancy. So those parents who believed most strongly in liberty, which is a political ideology, believed that government mandates on vaccinations should not exist. And those parents who believed most strongly in purity believed that vaccines were disgusting and unnatural. And those are actual quotes from parents. They thought vaccines were unnatural and didn't want to put them in their child's bodies. And then, as we've seen with COVID-19, around the world, religious leaders have called the COVID-19 vaccine the work of the devil or impure. And so again, really playing on these religious foundations of people coming from trusted religious leaders, this has an impact on vaccine hesitancy. And so the last impacting factor I want to focus on is a little bit different. So the ones that I've talked about, social media, education, religion, these are all more social impacting factors. This last one I want to focus on is access to healthcare and health insurance. So this is the breakdown of health insurance coverage in the United States based off the US Census. And in 2020, 28 million people were uninsured in the United States, and 4.3 million of those were children. 60 million Americans were insured through Medicare. Excuse me. So what does this mean? Well, if you're a child who is uninsured or insured through Medicare, you are eligible through Vaccines for Children for vaccine coverage. It's a program through the CDC. And this means that if you can drive to a certified healthcare facility, of which there are not many, you only have to pay up to $15 per vaccine. The CDC recommends 16 vaccines for children. So if we do simple math, that's $240 to vaccinate one child. If you're uninsured or insured through Medicare, it is likely you can't afford this. So now parents are having to decide whether or not to vaccinate their children or feed their family. And I can almost guarantee you most, if not all, families are going to choose to feed themselves and their kids, not to vaccinate against a disease they may never see. So they're playing the odds. And so this is a really important one to highlight, especially since we live in Vermont and it's so rural, that there are going to be families, there are going to be people who want to vaccinate their kids or vaccinate themselves, but they literally cannot afford it, or they can't get to a healthcare facility that's offering the vaccine. And that's something I really want to highlight, because a lot of times when we talk about vaccine hesitancy, I hear a lot of language about, well, that person's, just stupid or ridiculous, or how can they believe that? Sometimes it's really not a choice. Sometimes it's the situation they're in. So I always want to remember that and be compassionate with people. So I've talked a lot about the issues, but I want to highlight some possible solutions. The first one I want to talk about is to be understandable. You want to use the communication methods your audience is already using. Do not expect them to come to you. They're going to use Facebook. They're going to use Snapchat. They're not going to start buying the newspaper just because, the Department of Health starts issuing a column. You have to use the methods your audience is already using. And as I talked about earlier, use emotion, not just logic. Research has shown that information campaigns that seek to just combat the misinformation are not as successful as the information campaigns that seek to address a person's emotions. So you want to tell people why the vaccine is important and give them a reason to believe you. And the last thing I wanted to highlight is never assume a base of knowledge. Everyone you deal with will have a different education level, different experiences. Never assume someone knows what you know, and start from the beginning. And I want to give some specific examples of that. So here is a actual journal article that was published on COVID-19, and that's COVID-19 vaccine rumors and conspiracy theories, the need for cognitive inoculation against misinformation to improve vaccine adherence. Keep in mind that I study this. I did my master's on this. It took me a second to understand what in the world they were talking about. These are not easily understandable words, especially for those who don't have a high school education or have some equivalency, what have you. It's not easily understandable. So a possible way to rephrase this would be communicating correct COVID-19 information can work to address misinformation, which could help improve vaccination rates. That's more understandable. It's still not perfect. It's still very wordy, but it's more understandable. But this is what I'm talking about when I say be understandable, communicate at people's level. Again, we're in Vermont. If you walk into your community and I'll pick on Wallingford. If you go into Wallingford and start talking to people about cognitive inoculation, they're going to walk away from you because who knows what you're talking about. So communicating in an understandable way is really important. The next example I want to give is using emotion instead of logic. So on the screen, you'll see these are all things that can be used to describe a vaccine correctly. I'm so sorry. Vaccines are safe and effective. They're FDA approved. They use existing technology. These are all true. People don't care. It doesn't really engage them. So something else you can try is vaccines protect your family. They save lives. They let you live the life you want to. So again, all true, but one example uses emotion and one uses purely logic. I would encourage you to try engaging people's emotion because you'll have more success. So the next thing I want to talk about is engaging the community. So for the next two slides, they can be pretty ambiguous, but I will give examples. So there are as many reasons for vaccine hesitancy and low vaccination coverage as there are people in the world. And in order for you to help your specific communities, you need to understand your communities. And you can only do this by engaging stakeholders. And as emergency managers, I think we all know this. You need to form partnerships, and you need to invest in the community you're trying to help. And on that same thread, you need to be inclusive. So I think this solution is the hardest one I usually talk about, because as just humans, as people, whenever we hear something incorrect and we know the correct information, every instinct we have is to correct that individual, say, no, you're wrong, it's actually this. But you'll have more success if you approach the conversation with empathy and incorporate a person's belief into your argument. And so, like I said, I'll give some examples. So it's really easy to say things like engage the community and be inclusive, but what does that actually mean? So it means having conversations with people outside your organization, having conversations with people who have different opinions, different backgrounds, and different experiences than you. And so what this slide shows, I'm sure most of you are familiar with FEMA's whole community approach. So this is the idea that any person who could be impacted by a disaster event should be included in the planning and prevention process. And so addressing vaccine hesitancy is no different. So this is an example of a possible planning group. You know, you want to involve someone from local government, nonprofits, state government, tribal governments, private sector, community members. You want all of these people included so you can have as like overreaching a plan as you can, as inclusive as plan as you can. And so some specific examples that you could include in your planning process to engage the community, I would start with trusted community leaders. Start with religious leaders. I mean, we saw in the previous slides how much damage religious leaders can do because they're trusted. So we can recruit religious leaders to actually promote vaccines instead of promote vaccine hesitancy. Think how amazing that would be. Also engage BIPOC advocates, Black, Indigenous, and people of color. Those are often marginalized communities. So if you can get trusted leaders from those BIPOC communities, you can really make some headway. And then engage disability advocacy groups, advocacy groups for functional needs, children, those traditional vulnerable populations that are often forgotten about because the people doing the planning don't necessarily have those additional needs. And your instinct might be to think this is a medical issue, so I'll just rely on the medical field. So one thing I want to stress is that a new study was just released, and I was actually part of this research team, that showed that 1 in 10 primary care physicians in the US do not agree vaccines are safe. And so that's a mind-boggling number. And this really shows that the entire community should be used to address vaccine hesitancy. And you can't depend on one specific field because they're people too, and they have their own beliefs. So just because vaccine hesitancy is a medical field, you need to involve more people than the Department of Health and doctors. Really broaden your outreach. And I wanted to give an example of successful community outreach in Vermont, which was the BIPOC COVID-19 clinics that the Department of Health hosted in partnership with BIPOC community leaders. By engaging trusted leaders in the BIPOC communities and using an equity lens, the Department of Health was able to increase BIPOC vaccine uptake across the state, and it was wildly successful. And the last thing I want to highlight is that, remember, you're going to lose more than you win with this particular issue. It's political, people have their opinions, and they're going to fight to keep them. But we don't need a 100% success rate. We just need enough to reach herd immunity. And for the measles example, I know you're thinking, well, 95%, that's almost 100. But if you look at it through a smaller lens, if we, let's take a classroom of kids in a school. Let's say you have 20 kiddos, and only 18 kids are vaccinated against measles. There are kids who are susceptible. If you can just make one additional kid get vaccinated, that's 19 out of the 20, you've reached your 95% herd immunity rate. So this is an issue where one person can actually make a difference So even though you're going to lose more than you win, just remember, this is actually one of those real world issues that one person can make the difference. So if we can understand why people around the world are not vaccinating against different vaccine preventable diseases, then we can start to address the issue. And there is no one-size-fits-all solution to this problem, but understanding the reasons behind vaccine hesitancy is one key part to addressing the global health crisis vaccine preventable diseases pose. This is my contact information. If you want to email me, I'd encourage you to use my personal one because I won't be with the state of Vermont for much longer. But I want to take questions now if you have them, and thank you so much.
Okay, perfect. So anyone in the room, if you have a question, I've just asked that you come close to the computer so our presenter can actually hear you. So we will take questions, and for anyone that is dialing into the call, you can pop off mute and ask your question as well. Come on up, sir. How's it going? I'm the Vermont Reserve APLO, Patrick Kalish. I have a question just on like an ethical question regarding vaccines.
Sure.
I had my sister-in-law, she has 3 kids, young kids, and so on and so forth, lie to the person that was administering vaccines about her child's age. You know, I would say a white lie, 6 months difference isn't that big of a deal, you know, comma, ... But what's your, you know, general opinion on that? Is that, you know, at the end of the day, yes, she's getting vaccinated, and I agree that's the wise decision. However, it's going to vent against the advice of age and so on and so forth. Just, you know, getting your general opinion on it.
Sure. So with the caveat that I don't have a medical degree, ethically, I personally believe in not lying. You know, vaccines go through so much rigorous approval and testing, and the FDA approves for the ages that have been tested. So I know 6 months isn't, you know, a huge time frame to adults, but with kids' development, 6 months can be huge. You know, if you have a toddler, in 6 months they can start, I mean, I'm assuming I don't have kids, but they can start talking or crawling or what have you. So 6 months can really make the difference in childhood development. So I would really encourage to always be honest about your kids' ages when you're trying to get them vaccinated.
That was just a kind of ethical question for myself, you know, not necessarily that I'm going to doubt her or anything like that. She's a mom, so I understand. I was just, you know, kind of curious of what your official view was on it.
Yeah, my official view is don't lie, like trust the scientists. But I also know that I don't have kids, and that can be such a tough question, like personally and like you said, ethically. So, I mean, my personal opinion is be honest, but I think until you're in that specific situation, it's really hard to judge somebody else.
Thank you, ma'am.
Thanks.
All right, we have a hand up, Kelly Ross.
Hi, Abby. It's Kelly. I'm the EP specialist down in White River. Nice to meet you.
Nice to meet you.
Question. I have a neighbor, and she is adamant and has not got any of the vaccines or anything else. And I just came out of having COVID for a second time, and I'm vaccine boosted, and the Paxlovid did me in, caused worse symptoms than everything else. However, she was having dinner with my other neighbor, and my neighbor was letting her know that I had been sick and was bringing stuff over and leaving it at my back door so that they didn't have to come in, yada, 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 so to speak. And the woman piped up and said, well, that's because she got boosted. She got sick. And that's why she's gotten sick twice. And how do you approach somebody without offending them to say, you know, it's almost like we are trying to avoid her in the neighborhood because we don't want to have that conversation, but yet we want to be able to educate her because according to my other neighbor, you know, the neighbor in question that we're talking about, she reads everything, she researches it. Her husband got vaccinated in 1 booster, but nothing since, and she has none. How would you approach a conversation with that person? Because I don't want her to feel like she's being left out of the neighborhood, but I also don't want to intrude on her beliefs.
Absolutely. So I think there are two really important things that I want to mention. One, the difference between public health and then healthcare. So a lot of time, like healthcare and the medical field, they focus on the individual. And you'll see, and in your example, a lot of people who are vaccine hesitant will pull those individual stories. They'll say, well, you got sick, you got boosted, here's the correlation. Public health, as I mean, you work for the Department of Health, you know this, looks at the community as a whole. And so if you can avoid talking about these specific instances and look at the statistics, the public as a whole, there's obviously no correlation or causation between getting the booster and getting sick. I'm sorry you've had it twice. But if you look at the overarching statistics for Vermont or for the country, there's no correlation. So if you can zoom out, I always take that approach instead of going with the individual stories when you have someone that's so firmly believes. But then also, if you're not vaccinated, the CDC has new recommendations. You can still engage with the community. You can wear a mask. And so if she's really against getting the vaccine and is feeling left out, there are steps she can take. She can test herself. You know, the Department of Health gives out free tests. She can wear a mask. And so there are still ways to engage with people so they don't feel isolated while still maintaining safety for everybody. So those are the two things I want to mention with that specific question.
Oh, thank you. That sounds great. It was just more of, personal conversations we've had with her. I know that she doesn't currently wear a mask, but we also don't see her out a lot anyway due to some mobility issues. It was just more of getting in touch with her, having local, just right within the neighborhood here, without being offensive. But I like that approach where I can bring it out sense than doing it on an individual basis, because everybody's health is different. So they're going to react to, different things, and the vaccines are going to make people react differently, depending on their genetic makeup. So no, I think that's the next time I end up bumping into her or have a conversation or I'm talking with another neighbor, I'll try to bring it for a more broad perspective under the public health umbrella. But thank you.
No, you're welcome. And that kind of, I mentioned this, but I really want to highlight everybody's different. So I gave some like overarching examples, be inclusive, be understandable, but everybody's different. So the approach you need to take with everybody is going to be slightly different. And you can go their CDC, FEMA, they've released these frameworks that you can depend on or use as foundations, but you're going to have to tailor them to your community or even to individual people. So just remember to be flexible.
Sounds good. Thank you again.
Thanks, Kelly.
So I got a quick question. So for the people that get vaccinated and then for the people that don't, right? So it basically seems like no matter what, everybody's going to get COVID. Right? It's just kind of the natural path of it, whether you're boosted, whether you do your initial vaccinations to whether you're not. So myself being immune suppressed, I was vaccinated, I was boosted, and then ended up having to get the infusion and so forth, and it worked out well, right? But then I've known many people who were not vaccinated who got COVID and who did just fine. So what is your best sell for somebody that says, okay, hey, you got just as sick as anybody else did, compared to not getting vaccinated? What is the proof to show the difference, I guess?
Sure. So I think the proof is in, again, the public health statistics. So there's always going to be the individual standouts. And I'm sorry there seem to be so many watching who were those, individual cases where you got all the vaccines, you got boosted, and you still had a severe case of COVID. But the two parts with this is overwhelmingly the vaccine has been shown to be safe and effective. And also, even if you get COVID, you're much more likely, to survive, but also stay out of the hospital. And so if you're looking at it from, the greater good perspective, by getting vaccinated and staying out of the hospital, you are freeing up those resources that could be used to save somebody else's life. And so even if you get vaccinated, you get COVID, it's going to be less severe, and it's going to be for you individually, and then it's also going to help somebody else because you're not using resources that are needed to save somebody else's life. So there is that kind of domino effect with getting vaccinated. And obviously there are always exceptions. There are always going to be the people who get vaccinated, who get boosted, and then get a horrible severe case of COVID. And that is awful. But with public health, we always have to zoom out and we have to see how many lives are saved from COVID specifically, from getting the vaccine, but also the lives who are saved because there were resources available at the hospital, ventilators or personnel or ambulances who saved other people because they weren't being used on people who could have gotten vaccinated, didn't, got COVID, and now are using those resources. Does that make sense?
It does. Yeah. 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 I was just always curious, just basically because I've seen it from, like, I guess it's both sides though too, because I also worked in the basically, I guess it was the 911 field for like over 23 years, and being in that field, especially in a I guess it's Vermont, I didn't see that much of a difference, between, like, I definitely saw the hospitals getting overwhelmed to a point, but I never saw an issue with like any kind of ventilators, or anything like that throughout the state of, throughout basically our state. Now, if I look back home in Texas, right, they were very well overwhelmed compared to what our state was. So.
Well, and one thing I do want to highlight is your hospitals have done an amazing job in Vermont, but because there are so many communities that are rural and you have MOUs with your regional ambulance services or what have you, there has been an increase in response times with ambulances in Vermont because of staffing shortages, because they were overwhelmed during COVID or what have you. So even though the hospitals did well, you didn't have ventilator shortage, you're now seeing staff burnout. You're now seeing staff shortages and response time increases because of COVID. So I think that Vermont system being overwhelmed is appearing in maybe less traditional senses. It's not always going to be the hospital, but you're seeing it in the staff and response times. So that's something else to keep in mind.
Cool. Thank you.
Good. Any other questions? Anyone from the room? No one wants to come up here. That's okay.
And for those in person, I am here in the conference today and tomorrow, and you can always flag me. I obviously am happy to talk about this always. So if you have something that occurs to you, feel free to just flag me.